All right. Thank you all for joining us today here for our last webinar of 2022. Just a reminder, this is being recorded and will be posted on our YouTube channel after this. So I will let Elizabeth take it away and introduce our speaker for today.
Hello, everyone, and thank you for joining. And it's a beautiful snowy day here in Indiana, so I hope some others of you are enjoying this beautiful winter weather here a little bit early in the fall. But many of you have asked for technical assistance with your community mental health centers or with your CCBHCs, and this was actually an area that I think I didn't have all the knowledge and experience that I wanted to have. And so I'm very happy to be able to have Brock Lough join as a consultant. Brock is top notch. I was able to work with him previously as he was leading an FQHC with the CMHC, and also did some work with the CCBHC. So Brock has the mental health knowledge, and he's now leading a community mental health center, a pretty large one covering 4 counties in Southern Indiana, and he's doing an amazing job. So I'm really excited to have Brock on board with our team, even if it's part-time, and also excited for you guys to get to meet Brock. Again, Brock just finished his MBA and he's kicking butt in all areas. He used to kick a football, but now he kicks butt in healthcare. And he has a very cute son and a nice wife, from what I hear. So we're excited about that too. But again, Brock has done a lot in his short career because he is fairly young, but I expect great things for Brock for the future of healthcare, definitely in Indiana and all throughout the country. So now I will turn it over to Brock. Thank you.
Wow. Thank you for that warm welcome, Dr. Burrows. I probably should just stop talking now because all I can do, I think, is ruin what you've said about me. But yeah, I'm really glad to be here, really glad to be a part of the Burrows consulting team. You know, they do a lot of great work around the nation. We do a lot of great work around the nation, and really happy to have you all here today to talk about this really important movement that we call CCBHC, Certified Community Behavioral Health Clinic. I'm going to have Hannah help me out here with my slides today. So if you don't mind, Hannah, could you maybe help move on to the next? Thank you. So, you know, before we kind of get into the future and kind of give a little bit of technical assistance about some of the things relevant in CCBHC, I want to start a little bit about the history. And we have citations down here on each of these slides. And actually, would it be okay, Hannah or Elizabeth, if we send this slide deck out to the attendees when we get done? That way, if they need a reference, cool, I see a thumbs up.
Yep, we'll send the email with the FAQ and the slides tomorrow. So if you don't get that, please reach out, but we'll have it out tomorrow.
Great, thank you so much, Hannah. So just to start a little bit about the history of CCBHCs, you know, back in the Excellence in Mental Health Act, CCBHC was actually defined of these entities and what they wanted them to do, which was ensure access for people suffering from severe mental illness, chronic addiction, or comorbid conditions, as well as children with serious emotional disturbances. These CCBHCs were formed with that intent of providing access to these populations, people suffering with these diseases, in a similar fashion to what FQHC or federally qualified health centers have done. And you'll hear me reference FQHC several times today, as it is a parallel to the mental health, behavioral health world of what CCBHC is becoming. So originally, CCBHCs were defined in the Excellence in Mental Health Act, given some steam in the Affordable Care Act, the ACA, with care coordination, with health homes being created. But really, as you can see here, established some more movement with PAMA, the Protecting Access to Medicare Act. So the initial legislation allowed for 8 Medicaid demonstration states. And so we're going to take this conversation today from a broad perspective, knowing that we serve our whole country, and that some of you are from different states all across our great country. And allow for more specific questions. We'll leave some time for Q&A at the end. But everything I talk about today will be from a perspective of CCBHCs in general across the nation. Now, when these 8 demonstration states came out, they had funding from the federal government to help the state Medicaid agency and the state mental health authority allow a creation of a CCBHC certification. And so that also came with setting up a prospective payment system rate, again, parallel with the federally qualified health centers, as well as other value-based reimbursement per member per month type funding for these states. So that is when we say demonstration state, that is specifically what we're talking about. A state that the state Medicaid agency and the state mental health authority both have came together and created a CCBHC certification. So that actually has been expanded to 10 demonstration states now. The original 8 were Nevada, Missouri, Oklahoma, New York, New Jersey, Oregon, Pennsylvania, and Minnesota. There's been 2 more added since that time, and there actually will be 10 more demonstration states coming in July of 2024, which eventually is the goal of our Congress, of the federal government and the state governments alike, to create CCBHC across our nation in a similar fashion as FQHCs. If you go to the next slide for me, please, Hannah. So currently, there's more than 430 CCBHCs existing nationwide, and those original 8 demonstration states are about 66, 67 that were created. Since then, there has been an effort from SAMHSA to provide grants that have allowed many entities to directly receive funding and become CCBHCs through a SAMHSA certification rather than a state certification, directly with grant funding. So they report data to SAMHSA, which we'll talk about today, in the SPARS system, ERA Commons, other systems that SAMHSA has to report data. And they're funded directly from SAMHSA. Now, most of these entities that are grant funded, not in demonstration states, just provide service within their regular scope and are reimbursed through their regular fee-for-service models, state block grant funding, county tax levy funding. So these grants were an effort by the federal government by way of SAMHSA to provide money to community mental health centers, CMHCs, to really bolster up the number of CCBHCs. So it went from 66 originally in the 8 demonstration states to over, it's even over that number of 430 today where we stand. If you go to the next slide for me. Most of that money came from the CARES Act back in 2020, as well as American Rescue Plan Act back in 2021. So these 2 pieces of legislation, ARPA, as it's known, American Rescue Plan, and the CARES Act, provided money to SAMHSA to provide grant funding out to really spark the number of CCBHCs. And we'll talk about more about how those CCBHCs are operating today. But the future of CCBHCs is related to some legislation currently in Congress. The bipartisan Safer Communities Act has provided funding, $8.5 billion for CCBHCs to continue to help fund CCBHCs, as well as 10 additional states that will be selected for the demonstration program. So the long-term goal is to make CCBHC a permanent federal program. So that will include the prospective payment system, as we talked about. So Medicaid PPS, Medicare PPS, similar in the fashion that FQHCs provide, and potentially access, and there's been a lot of talk about this, to prescription drug programming like 340B that all federally qualified health centers are eligible as covered entities to participate in. Currently, there's a lot of states in their legislative session that are working on plans for creating, again, that CCBHC certification for each of their individual states. And that's something that, we'll really keep a close eye on state to state, and that if you do choose to engage with us to help you out, we can really have some good information about where your state's at in the process. If your state is already a demonstration state, how to potentially become a CCBHC, or if you're one of these new grantees that were just awarded back in September, what that looks like and what some sustainability is with your project. So one thing I should mention too is since the CARES Act and since the ARPA have been funding CCBHCs directly through grants through SAMHSA, there has been several different cohorts created to where they had 2-year grants originally. But this most recent funding that came out, I believe, is actually eligible. The recipients are eligible for a 4-year grant period for the CCBHC grant funding, which is typically in the range of a couple $1 million per year to kick off a CCBHC, to start a CCBHC. And we'll talk about what that means, service provision wise, compliance wise. If you go to the next slide here for me, Hannah. And that's kind of where we'll really start to get into the nuts and bolts of this. Again, we touched on the purpose of CCBHCs. It's really to expand the continuum of care, really to help enhance access. Prior to CCBHCs, there were very limited access to mental health services. After CCBHCs, just a couple stats that they had. Back in 2021, they're serving about 1.5 million. 50% were able to, of those consumers being served by CCBHCs were able to get same-day access, and 93% were able to get access within 10 days or less, which is something that CCBHCs are required to have. So really enhancing the access to care. That's the impetus behind CCBHCs for the behavioral health services, bringing again that parity between behavioral health and primary care. Next slide, please. So some of the criteria for CCBHCs: staffing. It'll be driven by a local needs assessment. So if you are a grant recipient, typically you have about a year to come up with that needs assessment and a community needs assessment. Now, if there's already been one done by maybe a hospital in your area, you can use other entities' community needs assessments. But that is something that you'll structure to continue to drive your staffing plan. You do have to submit a staffing plan when you apply for the grant. And you're eligible to make changes within your budget that you originally applied, as long as it does not move more than, I believe it's approximately 25% from category to category. So you may have like staffing, equipment, you can change your staffing within that category. But if you want to move to a different category with the funding you had allocated for staffing, if you're more than 25%, you'll be working with your GPO. Care coordination is something that has really enhanced and been created more with CCBHCs. Community partnerships is actually a goal, a measurable goal within CCBHCs. We'll talk a little bit about that. Quality and other reporting. There are some metrics that must be reported and measured on with CCBHCs. Let's go ahead and go to the next slide here, Hannah. So Appendix M is something that I want to talk about. So the authoritative document that's out there to help drive, there's a couple to help govern CCBHCs. One is your notice of award and your NOFO, or your notice of funding opportunity. That'll have provisions and specifications in it related to how your funding's spent, your project director, the time that must be allocated, reporting that must be done. Another document that's out there is the CCBHC demonstration criteria. And actually there is some updates coming to this criteria. Actually this week there's a meeting on November 17th that SAMHSA is putting on from 10 a.m. to 3 p.m. I believe it's called a public messaging meeting, but the title of it is CCBHC, the full name spelled out, demonstration criteria, public meeting. There are going to be some updates, and I believe even opportunity for public comment to the demonstration criteria. So the demonstration criteria is the authoritative document unless your state has a CCBHC certification, which is one of those original 10 states, right? Then anything that is outlined in your state certification from your state mental health or state Medicaid agencies would be more authoritative than the demonstration criteria. But one thing that's really important in the demonstration criteria is the Appendix M. Appendix M is a long list of provisions that you must attest that you meet to be a CCBHC. Things like certain partnerships that exist, like with the VA, for example, Veterans Administration, you have to have a certain partnership with other local entities. You have to attest that you provide any one service, regardless of their ability to pay, regardless of what state they may reside in. They want specific policies in place. So these are all things in Appendix M that are mostly quality and compliance related, but they're provisions that you must attest through a written attestation that you will submit to SAMHSA if you are a grantee, that you can attest to. And this is something that we can help you work through, help create a compliance checklist. Many clients and myself, when I worked in CCBHCs, we actually created documents for each specific bullet point criteria that they require. We've created a document to show that we suffice in meeting that requirement. For example, policies that you accept anyone to provide service to, regardless of their ability to pay. We had a policy in place for that we would show we met that requirement. So Appendix M is something that you should be very familiar with when you're a grantee. You know, so majority of you CCBHCs that are out there that are grantees, Appendix M is something that, you know, we'd be glad to help you work through, and that will govern you what it means to be a CCBHC from a quality and compliance perspective. The other system that's important for reporting is the SPARS, which stands for the SAMHSA Performance Accountability and Reporting System. The SPARS system is where you're going to be submitting data related to your CCBHC service provision that's out there. Specifically, data related to the NOMs, or the national outcome measures that you'll have for both children and adults. And so I will just touch a little bit here on the NOMs. That is something that a lot of CCBHCs that receive the grant have trouble getting set up because it's a somewhat cumbersome document. You know, it's somewhere between, I think, 20 to 30 pages that you must complete with consumers when they come in for service at a baseline. So you have 7 days from the first service that they receive to complete the NOMs, upload it in the SPARS system, and then you have to do reassessments going forward every 3 to 6 months. It kind of depends on what grant cohort you're in. And actually it references speaking with your government project officer about how often they want to see you complete those on a reassessment level. But that is something that's very important to your grant. It will be tracked. You will have an expectation between 70–80% of a reassessment rate that they want you to meet with these NOMs being submitted. So SPARS is something that is very important, and the NOMs is something, you know, we can absolutely help you set up a workflow for. It's something that, you know, if they're going to look at your grant to consider it successful, they're going to look at your baseline, which is the number of people that you serve. That's how it's counted. It's based off of how many unique baselines you enter and what your reassessment rate is. Those are two very big things that are going to be looked at and you'll be judged off of as a grantee. Also, states have set up NOMs measures and related measures that may be reported directly to the state system that are demonstration related. Next, can we go to the next slide, Hannah? Thank you. So this slide here shows the 9 services that are to be provided as a CCBHC. You can provide these services in a similar fashion to, if you're familiar with federally qualified health centers, they have the federally qualified health centers have a much more structured process to this, but this is where I see CCBHCs going in the future. Federally qualified health centers have the Form 5A, which is a document where you delineate the required services for your health center and where you provide them, whether you provide them directly via contract where you pay for it as a health center, or via referral where you have just a written agreement to refer. You are going to have MOU or a contract that you provide these services that you see on the screen here, or you have to provide them directly. Many CCBHCs are community mental health centers already. That's something that a lot of the grantees have in common. Some are not, though. And so it can be a big part of getting your CCBHC up and running. You do have a certain time frame where you have to get these services going, but as you can see, 24/7 crisis services is often one that is, I put it at the top of the list here because that's often one that if you don't have set up, that can be where you need to put a lot of your focus and a lot of your effort when you become a CCBHC grantee and getting started. And that's something we can help with as well. Staffing patterns, getting the correct policies and procedures in place, and making sure you're set up to get reimbursed as well. As I mentioned, CCBHC grant money is there, but it's more of a kickoff. It is finite. If you're a CCBHC grantee, you are going to be operating, and you're not in a demonstration state, which they are not. You're going to be operating off just the billing revenue that you produce, and maybe some of the other funding you may get if you're a CMHC. But otherwise, you are going to have to generate service revenue. So 24/7 crisis service is definitely something that we are glad to help set up. It really incorporates community partnerships, which is something that CCBHCs really are intended to expand on. There are other services on here that can be somewhat tricky to set up, but for the most part, most behavioral health entities are providing treatment planning, screening and assessment, outpatient mental health and substance use services, and they can be provided again via partnership. And if you can go to the next slide, Hannah, that's actually touches on it a little bit. And you can see, I should mention at the bottom, I will mention again, at the bottom of each of these slides, we have the link to the criteria for the demonstration, CCBHC demonstration criteria as it stands today. Again, there's going to be some changes coming on November 17th. But as it stands today, these are actually the references of where this information can be found. So, I mentioned about community partnerships being a vital piece to CCBHCs. That's something that is going to be measured with your IPP. IPP is another data form that you have to submit, similar to like the SPARS and the NOMS. IPP is another data form that has to be submitted, and it's more qualitative data, if you will. It's going to be community partnerships is one piece of IPP data that you have to submit, that you are making and have met with so many community partners. Board membership, you have to, in a similar fashion to FQHC, they want to see that more than half of your board attest to being either consumers or having family members, or knowing someone intimately. There's some specific language surrounding this. There's actually a little more leeway than FQHCs, which require your board members to be patients. CCBHCs, your board members just have to attest to being consumers of mental health services, or knowing someone or having a family member that is a recipient of mental health services. And we actually have a draft attestation that we can help you implement and help you be glad to work with your board and explain it to your board. There can be some concerns and questions sometimes, but that is something that's going to be IPP data that you have to submit as well. But these community partnerships can be a vital part to providing the services required to CCBHCs. There can be something called a DCO, a designated collaborating organization. So that is a formal partnership that you're structuring that has a written contract that shows, this DCO is providing one of those 9 previous services that you saw in the last slide, and could be receiving money as a subcontractor even if you are a CCBHC grant recipient. There's also a less structured, less involved relationship with an MOU, a memorandum of understanding, which is just a written agreement between parties, community partners that show that you are going to be referring and that these community partners are going to honor, some of the same provisions that you will honor in terms of seeing people, sliding fee scale, regardless of ability to pay, and so on and so forth, to make sure there's a good universal criteria of how these consumers are being served. So can you go to the next slide here, Hannah? Again, with the funding, there is, this are the two methodologies that are out there currently for CCBHCs to be reimbursed, just to kind of make sure this point is clarified. One, you have your Medicaid prospective payment system set up in those 10 states that have demonstration criteria for CCBHCs. Now, this will be coming, as I previously mentioned, with 10 more states this coming July of 2024, or so I'm told. And of course, there'll be more information coming out about that, not this coming July of 2024, 10 more demonstration states. But the current demonstration states that are out there do have prospective payment systems set up, as well as other funding mechanisms in place to fund CCBHCs. Now, each state does have some authority to create a CCBHC certification if a state Medicaid agency and the state mental health authority should get together and do that. But it just won't have this same funding in place with the demonstration criteria until that is eligible and out there for CCBHCs. Now, the grants, which is probably more so the audience that we're talking to today, those SAMHSA grantees, there was a cohort just awarded back in September of this year. And there's another cohort out there that should be coming to conclusion soon. Those grantees out there, those are the ones that we engage with most often. Those are the ones that are out there in the other 40 states that provide, the 9 services, report in the SPAR system, attest to meeting criteria with Appendix M. Those grantees are often who we work with to help develop these systems, but we can work in the demonstration states as well. If you go to the next slide here, please, Hannah. This one touches on, some of that demonstration criteria. Again, the PPS rate, similar to FQHCs, they'll be reimbursed on the cost of delivering that. So each state would have set up the cost report, and it's a very big undertaking, as you can imagine, because it restructures many of the systems already in place for mental health services. For example, here in Indiana, the state that I'm currently in, we have what's called MRO, Medicaid Rehabilitative Option, which is one of those 9 services you saw under that continuum of care, that psychiatric rehabilitation service, which often involves case management and skills in our state, especially. That MRO is exclusive to community mental health centers, which will become CMHC or CCBHCs rather. But that will have to be restructured into a PPS format if and when Indiana becomes a demonstration state or has that CCBHC criteria. Often that's going to involve a SPA or a state amendment, state plan amendment, SPA. So again, that's something that if your state is a demonstration state, we can help you find out information on if you can even become a CCBHC. Some probably have pretty strict criteria on who and how CCBHCs can be formed if they are a demonstration state. It may take legislation. It may be a specific application process through your state mental health, state Medicaid agency. Next slide, please. Touching on the grants one last time. So these grants provide that flat funding out there for CCBHCs who have to provide that 9 services. You do have a couple of cohorts out there. As I mentioned, there's actually a cohort out there right now. I believe there's 5 cohorts in total. As a grantee, you will be assigned a government project officer with SAMHSA on the programmatic side, and then you'll also be assigned a representative on the more budget or fiscal side. So you do have those two different representatives from SAMHSA, from the federal government, that will work with you as a CCBHC grantee and help you go through that. And as I mentioned, there's 5 cohorts out right now. So as you can imagine, there's a lot going on, a lot of different efforts, a lot of different grantee cohorts. Some have 2-year funding. Some are eligible for 4 years of funding. Some have received what's called a no-cost extension, where their 2 years of funding have ran out in time, but they still had funding left. So they got a 1-year no-cost extension to still to use their funding and provide the services to their community, but they still have to report in the SPARS system, meet the CCBHC criteria. And a lot of CCBHCs that are out there right now that are grantees probably have concerns about, being a grantee doesn't mean that's finite funding. What happens if and when the grants run out and your state is not a demonstration state yet? So there is states out there, such as Indiana, I know is working on some legislation in the legislative session right now to have bridge funding in place for when CCBHC grants run out, but Indiana is not a demonstration state yet. Those CCBHCs, if this legislation is approved, would have funding to get them from point A of being a grantee and that ending to point B of when it becomes a state certification and there's funding involved. So could you go to the next slide? Again, just hitting home on these resources, the Appendix M, that's that criteria compliance checklist that you will have to attest within a certain time frame of being a grantee that you meet these criteria. So this is something that we'd be glad to engage with you and help make sure that you meet it. And if you don't currently, we can help craft policies, procedures, workflows, make sure the right things are in place so that you do meet criteria on this, and then how you can attest to that and be sure that if there is ever a review or an audit or some type of looking into your grant as a CCBHC recipient, that you will uphold that you have met that criteria and your attestation will uphold. And then just mentioning as far as, again, that's that system where you have to report the NOMS, which is going to be one of the most important pieces of data as a grantee, CCBHC grantee, that you report. You're going to have your NOMS data and your IPP data. Those two pieces are essentially what your government project officer and the federal government will see you, a big portion of how they're going to see you as your CCBHC being successful or not, which can really play a large role in potential future federal funding that may come out. If your state maybe is not a demonstration state for years to come, and you are a CCBHC, there's millions of dollars that you will have received as a grantee that you put into staff, equipment, facilities, that you're going to have to sustain through service revenue, but also having that grant money continually will be helpful and be a bridge to getting fully certified as a state certification CCBHC. So making sure that you are reporting good data in SPARS is crucial. And so the number of consumers that you delineated that you will serve through your project period is going to be judged on the unique number of baselines that you enter with NOMS data in the SPARS system. And then your reassessment rate is going to be judged on the amount of those baselines that you hit within that time frame. There's a 30-day before and a 30-day after time frame of how long you have. So a 60-day time frame that you have the window to do that reassessment, 3 or 6 months out, based on your cohort, your GPO, and where you're at currently in your CCBHC grant award. It used to be 12 and 18 months and even further out, but they've shortened that now. And there's actually some more guidance that's coming out as there'll be some changes to the SPARS system, I believe, starting December 10th, about when those reassessments are due, what that looks like, what the discharge criteria, because there is a assessment that's done on the discharge criteria as well. So some important dates to remember, I should mention, is November 17th, this week, the demonstration criteria, which is what you're looking at on the screen right here, where Appendix M is at. There are, I believe it's a public comment period. It's a almost all day long meeting that SAMHSA has, webinar, with public comment and updates that are going to be coming out about the demonstration criteria, which is the authoritative document that's out there if you're a grantee, in terms of just the criteria to be a CCBHC. You know, you'll have your notice of award, your NOA, and your NOFO, the notice of funding opportunity, but there's areas of that that aren't covered, that are covered in the demonstration criteria if you're not a demonstration state or you're a SAMHSA grantee. So November 17th, that update's coming out, and then December 10th will be the time frame. Actually, it might be December 9th is when the change takes place. So yeah, December 10th will be when it takes effect, that date of the new SPARS requirements. There'll be some requirements in terms of different requirements in terms of reporting, the time frames, the NOMs. I believe they're going to make the NOMs shorter, which, as I mentioned, it can be a little cumbersome with that administrative work. So that'll be a good thing. That I think the feds, you know, with the CCBHC, it's been a pilot attempt in some regard of getting information and feedback. And that was actually this change with the NOMS data is from some feedback I believe that they've received from the CCBHC grantees that are out there thus far. So I'll go ahead and I know we have one more slide on here. If you want to actually, yeah. So again, just some good references. SAMHSA has a lot of information out there, but some of it can be very confusing. You know, they have guides on the NOMs and how to report that, but there is still some questions that and workflow issues that we would be glad to help set up and get you to optimize and run efficiently with. And also there's some information out there with the National Council for Mental Wellbeing. They have been a huge advocate for CCBHCs. Chuck Ignolia, the CEO, and his team have done a lot of work with getting CCBHCs to where they're at today, along with a lot of state agencies. So they do have some good resources out there as well. Just wanted to be sure to mention those. Then we can go, Hannah, to our last slide here, if you don't mind. Thank you. And this is just some information about our group, Burrows Consulting. You know, we have a monthly or a newsletter that comes out, talks about grant opportunities, has a lot of great information on there about different funding streams that we help our clients, have helped our clients successfully get, and are looking to help more people obtain grants. Policies, you know, we do have a new service of providing policy review and helping with creation and management, which is very relevant, as I mentioned a couple of times today, with the CCBHC world. Information out there about our upcoming webinars and events. This will be a recorded webinar. And my information, my email is here, brock@burrowsconsulting.net. I'd be glad to speak with you further about maybe some questions that you may have. I know we have a period coming up with questions here, but I'd be glad to speak with anybody about questions you may have, comments, or thoughts just about CCBHC. I love mental health. It's a huge behavioral health. It's a huge passion of mine. One thing I will mention too is, you know, we have experience here at Burrows Consulting, which is very relevant to CCBHCs, with helping set up clubhouses. You know, we've been a part of getting several clubhouses, the International Clubhouse Accreditation, getting them through that process, getting them through the conditional 1-year accreditation that all clubhouses go through, setting up fundraisers, setting up transitional employment, TEs, really engaging the community, setting up advisory councils, policy and procedure manuals for those clubhouses, and getting to where if your state offers it, you get that Clubhouse International accreditation and start being able to be reimbursed by Medicaid in your state as a clubhouse, if that's something that your state offers. So, you know, we have also have experience with working and setting up mobile crisis teams, which is another huge part of the CCBHC effort. You know, and there's that other wing of the 988 national hotline that's out there that, you know, you have all these pieces kind of working to structure the future of behavioral health. So really have some best practices with that, you know, a checklist of mobile crisis team of when you get certain calls, what needs to be in place before you go out to determine that it's safe. How many times do you need to train staff members until they're able to go out? You know, what is the model for staff who goes out? You know, is it teams of 2? Is it teams of 3? What are the disciplines? Are they clinicians? Are they case managers, peer recovery specialists? So really have some best practices in helping set that up. And that actually have been a part of setting up some really great relationships, again, with those community partners, criminal justice entities, to where dispatch, 911 dispatch in that county or several counties is contacting us as the CCBHC, and we're sending out our mobile crisis team when it's certain situations that meet the criteria where police, law enforcement have determined they don't need to go out. Dispatch will contact us directly and we'll be the ones to go out. But that takes a time, that takes commitment on both ends to foster and build that relationship. But that's something that we've been a part of here at Burrows Consulting. We'd be glad to help structure and set up as well. I will kind of pause here now, Hannah, Elizabeth, and provide some opportunity for questions because I know we wanted to have a little time for that.
Awesome. Thank you so much, Brooke. This has been great. Keep in mind, you can still put questions in the chat, but I'll read off the few that have rolled in so far. So first, if I wanted to start a CCBHC, what would be the first steps I need to take?
Yeah, that's a great question. So it depends on what state you're in. That is a vital part of this journey. If you're in a state that is a demonstration state, one of those initial 8 that I named off, or 2 of the newer demonstration states, the best thing would be to engage us here at Burrows Consulting. We can help you navigate your state code, the certification process through your mental health agency and Medicaid agencies, your state Medicaid and mental health agency and authorities, to determine if there's opportunity. Most of the time it's delineated by counties. A lot of states have, you know, certain or regions, a multitude of counties where they have CCBHCs that are the CCBHCs for those counties. So we can determine that process and see what counties may be available, or what counties make the most sense through gathering some data. And that's one route. If you're not in a demonstration state, you know, you can engage with us. You can also sign up for grants.gov and samhsa.gov notifications, so you can be aware when those new grants are coming out. There's CCBHC grants that come out that will be awarded directly from SAMHSA, so you can lock in one of those grants, and we'd be glad to. We have engaged and wrote a lot of successful CCBHC grants, and we'd be glad to work with you and your team to make sure that the consumers that you're serving have that high level of service as becoming a CCBHC.
Perfect. Next question was, what was your biggest challenge when working with CCBHCs?
Oh, that's a great question. So I think one big challenge becoming CCBHC, I kind of mentioned some of them when I was going through, but definitely the NOMS, getting the NOMS data and getting a workflow to collect that information, because I understand why the federal government created these NOMS and where they kind of came from with measuring data, but it's paperwork, you know, it's burdensome. And we know our clinicians, we know our providers have a lot of administrative burden on them in many of our states. I know it kind of varies state to state, but a lot of states have a lot of paperwork that people have to do in an intake or in an assessment. So adding another layer of that is not looked upon favorably by your clinicians, by your providers, but it was a necessity. You know, as I mentioned, NOMS data, SPARS data is how, if you're a grantee, the federal government is going to see you with the number of people that you serve. So it's vital to get those done within those first 7 days. It's vital to have somebody else who can put it into the SPARS system. And then it's vital to have a system track when that consumer's coming back in and when that reassessment should be done. And then again, put into the SPARS system. So getting that set up is probably one of the most difficult things about becoming a CCBHC grantee.
Perfect, thank you. Next question, what is the difference between an FQHC, CMHC, and CCBHC?
Yeah, great question. So an FQHC is a federally qualified health center. It's a designation that comes and is awarded through HRSA under the HHS umbrella, the Health Resources and Service Administration, I believe, HRSA, HRSA is the acronym. They have, as I mentioned, a plethora of services that they have to provide, one of them being primary care. They focus on primary care. They provide also behavioral health to a degree. That's a service that can be provided at FQHCs. But they started out being called neighborhood health clinics, I believe, which is really kind of their focus, you know, family medicine, serving the underserved, serving people that may be indigent. That is a federally qualified health center. Community Mental Health Center, or a CMHC, was something that was created back in the 60s when President Kennedy signed the Community Mental Health Center Act. This created this new designation that is awarded by states and controlled by states. But it is, as it sounds, a community mental health center. It's focused on providing behavioral health services and substance abuse services. And it varies greatly state to state. So that's kind of the two players you've had historically over the last couple of decades. Federally qualified health centers that provide the primary care service, awarded and regulated by the federal government. Community mental health centers that provide behavioral health and substance use disorder services, regulated and awarded by states. CCBHCs is actually that creation in the middle, that newer creation that falls kind of right in the middle of these two entities, if you will. CCBHCs, it's the intent of the federal government for them to eventually take over CMHCs, or for CMHCs to become CCBHCs. CCBHCs are the federal government's future of behavioral health services. So they're awarded currently by states, but there is federal government channel to CCBHCs, even by way with the grantees through SAMHSA. They're creating universal services. All CCBHCs provide those 9 services. Now there may be some nuances within each state, and it also provides that prospective payment model for the demonstration states that will be to come as we develop more and more demonstration states. So you have federally qualified health centers regulated by the federal government, providing primary care mostly, and a list of services. Community mental health centers that are regulated by states, and CCBHCs, that new creation of where community mental health centers are going to better align with the way that federally qualified health centers do for behavioral health services.
Perfect. That was a great explanation. And then last question that we have coming through is actually about 340B. So I know there's a number of pathways that 340B can help health centers. And so do you think that CCBHCs in the future will have standalone access to 340B like FQHCs do?
Oh, yeah, that's a great question. You know, I truly don't know. I would have to kind of dig into what it is that allows federally qualified health centers to become covered entities that can then participate in 340B program. But I've heard a lot of talk from various entities that are involved with the CCBHC effort about CCBHCs being able to participate in 340B and becoming covered entities. You know, I think there's obviously some precedent with FQHCs and how they do it, and it's a great program. It would make a lot of sense. There's a lot of parallels, as I've mentioned, kind of all this entire presentation between FQHCs and CCBHCs, and 340B would just be another one of those that I could see coming about. But to my knowledge, there is not currently any provision for CCBHCs to participate in 340B programming. But I know it's on the agenda for some of the advocates for CCBHCs, and it definitely would make sense and align well with that programming. So yeah.
Perfect. Thank you. Well, I don't see any other questions, so this will wrap up our webinar. Like I mentioned at the beginning, this will be recorded, posted on our YouTube channel, and also emailed out to you tomorrow, along with the slides. You all, as a part of registering for this, have been included in our newsletter, but if you think of anyone who would benefit from that monthly newsletter, please share that link with them as you see fit. And thank you for attending today.
All right. Thank you.